You ever wonder how a doctor's incredibly complex, life-saving surgery gets translated into a simple string of numbers? Well, it's not magic. It's actually a hidden language, a really detailed blueprint that maps the human body. And today, we're going to decode that blueprint for two of our most vital systems, the heart and the lungs. So here's our game plan. We're going to start with the big picture, right? The two-system blueprint itself. Then we'll dive into a super simple case study, a nosebleed of all things, just to get the basic logic down. From there, we'll see how that exact same logic applies to the much more complicated world of the heart. And finally, we'll pull it all together and reveal the four fundamental pillars that are basically the secret language of this entire system. All right, first up, the core architecture. You have to think of the heart and lungs as these inseparable partners. They work together constantly. So it just makes sense that the system for coding procedures on them would reflect that deep, interconnected relationship. And you can see that division perfectly here. The whole cardiopulmonary world is basically split into two domains. You've got the respiratory system, where we're looking at things like airway management and epistaxis, which is really just the fancy medical term for a nosebleed. Then, on the cardiovascular side, we get into the heavier stuff, bypass grafts, interventional radiology, and pacemakers. Okay, let's jump into our first case study and actually see this blueprint in action. We're starting with something everybody gets, a nosebleed. Seriously, it's the perfect, simple example to see the fundamental logic before we tackle anything more complicated.
So, just so we're all on the same page, here's a quick look at the anatomy. Our case study is happening right at the front door of the system. The nose, the nasal cavity, all part of the upper respiratory tract. It's basically the front line for all the air coming into our body.
Which, brings us to the big question. How on earth do you take a common thing like a nosebleed and turn it into a specific, universally understood medical code? How do you capture the details that actually matter?
Well, the answer is in this simple but kind of brilliant matrix. What's so cool about this is how it turns a real-world event into clean data. A coder just has to ask two simple questions. First, is the bleed coming from the front, anterior, or is it flowing back, so posterior? And second, was the fix simple or complex? Based on just those two answers, you land on one specific, unique code. That's it. That's the core logic, and you're going to see it pop up again and again.
All right, now that we've got the logic down, let's apply that same way of thinking to a much, much more complex organ, the heart. We're about to see how that simple process of just answering a few specific questions can guide us through some of the most critical procedures in all of medicine. Let's kick things off with a coronary artery bypass graft, or CABG as it's known. This is a procedure to restore blood flow when an artery gets blocked. Now look at this flowchart. The very first decision point for a coder isn't about the patient's condition, it's about the material the surgeon used. Was it a vein graft, an artery graft, or a combination of the two? That single detail decides the entire base code. But here's where it gets really interesting. The key is knowing what's bundled into that base code and what's not. For instance, taking a saphenous vein from the leg to use in the bypass, that's so common it's just considered part of the main procedure. You don't code for it separately. But harvesting a vein from an arm, that's less common, it's more work, so it needs its own separate code. These are the kinds of details a coder has to be a master of. All right, let's switch gears to cardiovascular interventional radiology, or CVIR. This is all about using catheters for diagnosis and treatment. The most fundamental difference here, as you can see, is between non-selective and selective placement. In other words, is the catheter just sitting in the main artery, or did the radiologist have to skillfully navigate it way down into a smaller specific branch? That single difference is everything when it comes to the code. And this is how that journey gets turned into a code. The base code is 362, but the last two digits get built like a tiny algorithm. The fourth digit tells you where the journey started, above or below the abdomen, and the fifth digit, that tells you how far the catheter went down the arterial tree. It's basically a numerical map of the surgeon's path through the body. Pretty cool, right?
So sticking with that idea, let's look at central venous access procedures, or CVAP. The name itself gives away the first and most important coding question. This map shows it perfectly. The main distinction is location. Was the catheter put into a big central vein, like the jugular, or a smaller peripheral vein out in the arm?
And that first question? It's just the top of a decision tree. To get the right code, a coder has to work through 4 questions, in order. 1. Location, central or peripheral. 2. Tunneling. Was a pathway made under the skin? 3. Device. Was a port pump used?
And finally, number 4, a patient variable, their age. Yeah, you heard that right. The patient's age can actually change the final code.
This logical, step-by-step process applies everywhere, even when we move from catheters that are just for access to devices that actively manage the heart, like pacemakers. These incredible little things use electrical pulses to control an abnormal heartbeat. And for coding, all we need to know is its 2 main parts: the pulse generator, that's the battery and the brains, and the electrodes, or leads, which are the wires that deliver the pulse.
Because those 2 parts are the key to the coding variables. A coder has to check 3 things in the surgeon's report. First, the insertion method. Was it placed on the heart's surface, or was it threaded through a vein? Second, lifespan. Is it temporary or permanent? And here's a great little rule of thumb. If the report doesn't say, the default is always permanent. And third, the action. Was it a new placement, a removal, or a replacement? And if it's a replacement, you actually need 2 codes, one for taking the old one out and another for putting the new one in.
So we've gone all the way from a simple nose bleed to a complex pacemaker. I know, it feels like a massive leap, but now we're going to zoom all the way back out, and I'll show you these simple, universal principles that connect every single one of these things. This is the universal grammar of surgical coding. It might seem really complex, but I promise you, everything we just went over, from the most basic procedure to the most advanced, it's all built on a foundation of just 4 fundamental questions. And here they are, the 4 pillars of procedural coding. This is the secret language right here. First, anatomical site. Where did it happen? That's our anterior versus posterior nose bleed. Second, surgical approach. How did the surgeon get there? That's our pacemaker being put in through a vein versus on the heart. Third, device complexity. What hardware was used? Think about a simple catheter versus a complex pacemaker. And fourth, component bundling. What's included and what's extra? Remember those bypass graft harvesting roles? Every single code is just a combination of the answers to these 4 questions. So the next time you hear about a medical procedure, remember this elegant, logical system that's working behind the scenes. And it kind of leaves us with a final thought, doesn't it? What does this hidden, logical blueprint for the human body tell us about the future of medicine, where data and biology are becoming more intertwined than ever before?